Let's discuss the surgical removal of a fairly straightforward impacted lower third molar tooth. Tooth number 17, as you can see here, is fairly vertical, although tilted a little bit to the mesial. You'll also notice that covering the distal aspect of the crown is a little bit of bone, and so I would classify this as a partial bony, vertical impaction of tooth number 17. The rationale for removal of this tooth is that any third molar that has not or will not come into complete functional occlusion and can be easily maintained by the patient should be removed because it's going to exhibit pathology as the patient gets older. The key pointers to this procedure, first, is to mentally visualize the procedure from start to finish. And so because you know all the steps that you're going to go through, you know all the instruments you're going to need, and so you want to have them available either on your surgical tray or close at hand. Also, you want to minimize soft tissue trauma and also get access and see what you're doing. And so you need to lay an adequate soft tissue flap so that you can get access and visualize the area where you're working without having to stretch and tear the tissues. On the instrument tray, you want to have a complete set of instruments to complete your task. And that means having a retractor to get the soft tissues out of the way, scalpel blade, periosteal elevator, curette, some hemostats, small and large, an extraction forceps, of course local anesthetic needle, mouth prop to support the patient's jaw, a variety of dental elevators of different configurations, suture, needle holder, and suction. There are a variety of incisions that are used for removal of lower third molars for surgical access to the site. As you can see here, there are quite a few. The one I like to use is this one that is indicated by the letter F. So here we are. We're going to remove this impacted lower third molar, number 17, which, as I mentioned, is a partial bony. The incision is made beginning in the sulcus between the first and second molar and then carried posteriorly up to the lateral aspect of the ridge. Periosteal elevator is used to lift a full thickness mucoperiosteal flap, and then you can use a scissor to cut through some of the fibrous tissue there. And also I cut out a little triangular wedge of tissue over the mesiobuccal aspect of the tooth in order to increase my access to the area. Now I'm taking a periosteal elevator and pushing it onto the tooth so that I can lift the soft tissues over it and fully expose the tooth. And then we take our handpiece and we remove the bone that's in the way. And a trick that I learned in my first year of residency, actually in my first week of residency, is that tooth enamel is much denser than is bone. And so if you take your handpiece and with very gentle pressure, lay it against the crown and just sweep it back and forth, you'll end up removing bone and leaving the crown of the tooth fairly intact. Once you removed all the bone, you try to elevate the tooth, and you see that it does move very freely. However, there's soft tissue covering the lingual aspect of the crown, and so you can use a periosteal elevator to retract those soft tissues out of the way, and you can see that the tooth elevates out very easily. You can then just grab it with a small hemostat and remove it. It's also very important once the tooth is removed to remove all of the soft tissue and follicle from within the socket. If you leave follicular tissue there, it has a possibility of degenerating into a cyst should there be any inflammation back in that area anytime in the future. So you want to be able to be sure to curette that out very thoroughly. Once you've removed all the soft tissue, you go back with a bone file and smooth off the bony edges so that they're not sharp and there's no little bony splinters. You then irrigate the area, flush it out real well, and then you can go ahead and close. And I put a single stitch between the first and second molar, and go ahead and tie that. And you'll see the incision at the distal aspect over the third molar, I actually generally leave open. When the cheek is reapproximated, you'll see that incision actually comes back together pretty well. And we know from studies that have been done that if you close the incision in a watertight fashion, that the patient actually has more post-op swelling and discomfort, and so you're actually better off just to leave it open a little bit so that it can drain. And so basically that's all there is to removal of a fairly straightforward mandibular partial bony impacted wisdom tooth.